Recording. Recording has started. Good, because you want to be able to look back on this. Okay, so let's share again. I almost forgot about that. And start again. Yes, it's recording.
You're applying to our national community of professional scientists. As part of your application, you'll be completing a competence report. This is the main part of your application, and the bit where you get to tell us all about your role in making science happen. The competence report has 5 sections. It is important to assessors that you provide key details. This short guide will help you write a competence report that maximizes your chances of being accepted onto the Science Council first time round. Before we look at the competence report, let's think of some moments in your career that you are especially proud of and write them down. Times when your actions brought a project together, when you turned a problem into a solution, or when you completed a task to a very high standard. Nobody but you will see these notes, so write down whatever you want. Next, let's take each example and think about what skill it highlights. There are no right or wrong answers. You're just untangling your experience into separate skill sets. For example, let's say you improved the way a sample is collected. Which skills did you use? If you had to interact at length with a colleague, then that's an example of interpersonal skills at work. If you had to read up on a theory or technique and then put it into practice, then you're applying your knowledge. If you sourced some new equipment or a new method that would save time or money, then those are process improvement skills which contribute to your professional practice. We want to understand not just what you know, but how your understanding informs your problem solving. It can be helpful to look at verbs as clues. For instance, if we ask you to tell us how you assess and select appropriate scientific techniques, procedures, and methods, the keywords are assess and select. Don't just tell us what technique or procedure you used. Tell us how you decided it was right for the task so we can see your reasoning. The prompts will be slightly different for each register. But if you are asked how you analyze, interpret, or evaluate something, use these as hints when drafting your response. When do you take personal responsibility in the workplace, either for yourself or for others? Maybe you write risk assessments for your laboratory, or perhaps you once saw a recurring issue in a standard practice and shared a better alternative with your colleagues. We want to see that our scientists can demonstrate superior people skills. In this section, you will demonstrate communication between colleagues, peers, and decision makers. This section is about procedures, methods, and resources. Think about times when you have chosen various methods and techniques, and any steps you've taken to improve resources in your workplace. We want to see that you understand your relevant codes of conduct and practice, and can explain why they are necessary and how you adhere to them. Show us how you maintain and enhance your own professional development. How do your examples fit into each of these areas? Some might fit into more than one. If you need to, go back and explore each section again. Once you see which examples demonstrate each competence, you can start writing your report. Let's look at what a good report looks like. Your opening few lines outline the problem or situation, or give an overview of the task you're going to describe. Now, tell us what solutions you proposed, or how you made your task work, as well as what you did. Tell us why you did it, and relate it back to the subject heading, like knowledge or interpersonal skills. Use I as much as possible to tell us about your personal contribution. Next, write about how you implemented the solution, or how you overcame the problem. To make your answer especially strong, round off by relating this back to your day-to-day job and how it enabled you and your colleagues to do a better job in the long run. Your example may be more or less complex, depending on which register you are applying for, but the principle is always the same. This matrix will help give you an idea of the level your competence report should be at. You can either pause here or find the links at the end of the video. A very common mistake to make is to just include your inputs. Outputs are even more important. They show whether your skills are making a difference. Here are some simple examples. Make sure you include outputs in every section. Finally, it's a good idea to ask your mentor or sponsor to check your application before you send it. We have lots of resources to help you complete a brilliant competence report. If you need more help, just email us. Remember, the competence report is just about proving the things you already know. Good luck.
Right. I'm going to go back. Sometimes it gets stuck on videos, and I'm going to go to play from current slide. Now, Lucy, before we go any further, so I'm just obviously you've probably seen this before. This is an overview of what an RSci Tech is. So I'll just sort of clarify or reaffirm that, okay, in terms of what they can do and perhaps what they're not expected to do, even if they do it, or demonstrate through their competency answers. But can you remind me, when we talked about the fact that you wanted in effect a workshop that was RSci Tech sort of focused, in terms of going forward with the presentation skills that I've given, tips should I say, that I've given to you and Charlotte, what sort of thing do you envisage doing in the near future? Can you remind me again, Lucy?
So it will be more sort of presenting to fellow APTs who are wanting to get involved in RSci Tech, don't quite know where to go. Because now if you want to do the next level of the qualification to be an APT, so level 4, you have to have your RSci Tech as a minimum to then go on to the level 4. So there's more appetite for it, but because obviously with the wording of the standards themselves are quite broad, a lot of it is trying to make the world of APT fit, because it is very sort of lab centric, the language.
Absolutely, yes.
So it's making it more sort of, when they say, scientific techniques, or they say, what we can do is think about a time in the PM room and different suturing methods, or fixing a sample or whatever. So it's more sort of making it a bit more relevant for my folks.
No, I mean, I've always said that. I've been giving workshops in various capacities for various registers, all of them, or one or two like this, since 2018. And the one thing in the first year that became really apparent to me is the wording of the competencies. Even though it's generic, I still think there's an inherent bias towards people who work in labs. I take your point here, which is why it will be good for us and good for me as well as you, to sort of, when I come on to competency A in particular, for you to sort of discuss what you do and let me know if the prompts that I've given and the things that I've talked about sort of relate to things you do on a day-to-day, week-to-week level, Lucy.
Yes, perfect.
Right, so let's just basically put some skin on the bones, as it were. So what is an RSci Tech? Okay, so an RSci Tech is not a rookie. It's someone with 1+ years experience that expected to demonstrate that they're working at level 3-4 in terms of skills, knowledge and behavior that obviously you inculcate through your competency answers, that, as you know, are really like a working portfolio, right? So they can work with minimal supervision. They can interpret and evaluate data based on the standard operating procedures that they have been trained in, maybe by higher technicians or academic, and they can recognize problems and apply scientific methods to a limited extent. But I think that the big difference between an RSci Tech and an RSci is you're expected to work independently and understand what quality data is, and that the latter in particular is the subject of competency A3, and we'll come on to that when we unpack the competencies. What, however, you're not necessarily be expected to demonstrate through your competency report, even if you do it, which in many cases is true, that you have sufficient sort of knowledge and understanding and moreover experience that you can improvise on a standard method. You can troubleshoot. In other words, the standard operating procedure becomes non-standard. Okay, so as an RSci Tech, you're expected to understand why you choose the method that you do and the science behind it. And as we'll say, in effect, that's competency A1. Competency A2 is understanding that there might be a menu of methods in terms of samples or different contexts that you can select. So you're not expected to improvise on a standard operating procedure, but you are expected to show awareness of the fact that depending on the samples you use, I'll let you enlighten me, Lucy, and we'll talk around this to try and firm up your own ideas, that you can select, if you like, the most optimal method, but that optimal method is still standard. Okay, you don't have to basically go back and sort of try things from scratch, even if as part and parcel of what you do, Lucy, as a practitioner, and you can tell me you do. A3 is about, okay, you've got data. Can you recognize problems with that data? Is that data, can you recognize what constitutes good data? You know, is it fit for purpose, etc., etc. So that, in essence, is what an RSci Tech is. And if we look at the competencies in the round, the 5 principal categories, and we're going to break these down in terms of RSci Tech, not just in terms of these 5 principal categories, but the sub-competencies thereof. There are knowledge and skills which apply to how you do things in the workplace in terms of wet science, whatever that means to you. As you say, you're not in a lab, but you will have STEM practice, and that's what that means. It's knowledge and understanding, and you have to enunciate what you do and moreover why you do it. And as I say, A2 is about selecting maybe more optimal methods. A3 is looking at the data. Is it good? Is it not good? If it's not good, what do you do? Okay. Personal responsibility is really about how you plan and organize different things that you do, not necessarily just for yourself in terms of your own working agenda for your supervisor, but perhaps other people you interact with in teams, or just people you share the lab with. And that might mean maintenance, for example, of different pieces of kit, because whether you work in a lab or whether you are an anatomical pathologist, there are machines that you will use. Okay. And let me just say that application of knowledge and understanding is about how you keep those machines in working order. Are there housekeeping protocols, for example, that you use to maintain them? And that isn't just for yourself, it's for other people, impacting on B. And B is also about working to certain standards. Okay. And normally that is synonymous with health, safety, and COSH. Interpersonal skills is about how maybe you train others, how you are more so as an RSci Tech, how you may be trained by others. Okay, and that isn't just the standard operating procedure, that's the associated good laboratory practice that ties in with things like COSH and risk assessments. Okay, but it can also be about, as we'll see when we break down the individual sub-competencies, it can be about effective teamwork as well. Professional practice in the context of RSci Tech is about how you might want to update methods, or perhaps work to different standards or standards you currently work to. And we'll expand on that in your case, Lucy, that perhaps you've touched upon in A. So I think there is a relationship between A and D. Okay. Knowledge and skills really, I think, encapsulate competencies A to D. If you look at the language of an apprentice, although apparently under Skills England it's changed now or is about to change, there is the E as well. There is B as well, behaviors. And professionalism is really about how you interact with people and data in a professional sense. Okay, so it's about data protection, equality and diversity, ethical practice in the workplace. So you could actually say that that's as much behaviors as it is knowledge and skills which underpin those behaviors. So I thought what I'd do is just basically give you the actual extant sort of summary statements of what is needed for an RSci Tech. And the first thing I'm going to ask you, Lucy, and I think the answer might be yes, is am I right in thinking that you have come across this matrix, which actually was shown in the video?
Yes, yeah, I have.
Okay,
Yeah.
so are you, I don't want to sort of talk you to death, but are you therefore familiar with the sort of different delineations, the different mission statements for an RSci Tech competency? I guess as somebody who has RSci Tech, you probably are, aren't you?
Yes, yeah, and obviously have been now being an assessor that helps sort of drive it home a little bit more, because I've read more than, because I only did mine once and got it passed once, but obviously I've marked quite a few, so it's nice to know that that's taken root, and I'm thinking, oh yeah, that's what I'm looking for, and this is what I want to see people writing about and reflecting on and all that kind of thing. So
yeah, I mean, given that you know that, I just want to point out one or two salient things, but as an assessor as well as someone who holds RSci Tech, I may be preaching to the converted here, and in many ways that's good. So as an RSci Tech, it's about being able to work independently, but knowing when to elevate things. Because as I say, independence may not go as far as being able to improvise on methods based on additional knowledge, skills, and experience. That comes really with RSci. So RSci really is an extension of RSci Tech, and CSci I always think is a more of a standalone beast. And that's what it means by works with minimal supervision, but knows when to escalate. So it's knowing protocols or pathways about if data that you see is not up to scratch, what do you then do if you need additional help? Effective communication is really, that sort of goes to the heart of what was in the video, which is outputs. Because as an assessor, I'd forgotten you're an assessor actually. As an assessor, you will know that you have to basically clarify and to some extent affirm the things that you're talking about. In other words, have they been effective? So effective communication sort of is consonant with the idea that the thing that you're talking about, the thing that you've trained somebody in, or the personal problem that you're looking at has been solved. In other words, it's what you've talked about in some context is effective. Okay. And then professional practice is about standards, continuous process improvement, and we'll talk more about how you do that in your environment. And as I say, E is really different codes of conduct, and maybe you can enlighten me as to what those are within your own area. So that's as much behaviors as knowledge and skills. And I just want to apologize. This is sort of really goes back to what you said about the bias towards lab work. But remember that competency A is not just sort of your empirical STEM practice, your wet science if you're in a lab, or what you do in a morgue, let's say. It's also related to the fact that you use, maybe in your case, different monitors, okay, in your training, simulations, and in practice. And we'll talk, you can tell me about this. So it's much about the equipment as anything else, but it's also, as I say, it's also about being the subject of health and safety reviews, lab inductions, etc. And in terms of the practice, your technical practice, it's also about any literature searches you've done based on problems you've found, or in order as a new person to actually get up to speed with what it is you're meant to be doing. Because what's important, as you know, in an RSci Tech competency form is demonstrating understanding, not doing something novel, but putting a standard operating procedure into practice and being able to explicate why you use that method. Okay. And to some extent, that is about work-based learning, experiential learning being taught, but it's also maybe about literature searches that you've done at your own behest, or ones that you've been pushed in the direction of. And I've just put the fact that this sorts of scenario, no competency is mutually exclusive. You know, when we do things and we talk to people, we're practicing our technical skills, but you know, if we work in a team, that's interpersonal skills as well. It's C. So there are no real divisions between them. You know, they're all interrelated, which is why in a competency form, you can take one scenario and recontextualize it as an RSci Tech. And one example will do. But as I've said to you before, I think, Lucy, I always think it looks good from an assessor's point of view if they are doing a little bit more, if they can use different scenarios for different competencies. But you don't have to. And let's stop actually on this, because what I've tried to illustrate with B in terms of planning and organization is how you would try and balance your reading and your STEM practice, including upkeep of equipment, with maybe other things, in this case, that you do in a lab, but in your environment. So why don't I hand over to you for the first time and try and expand? If we look, say, at things like planning and organization in competency B, how would this, because this is clearly someone in a lab taking care of things as well as doing their own personal project work, how does that transpose to your own situation, Lucy, as an individual working on a project, or maybe working in teams with others, and responsibility towards others in terms of upkeep of equipment that you might use? So you get the idea. So if you want to just sort of elaborate on that a little bit.
So that does actually that translates over quite well, especially at the moment. So before I leave and go to Yorkshire, I am currently the only substantive APT at Ipswich Mortuary.
Right.
I'm working, there's me and there's a locum. The locum happens to be my husband. But a lot of that, again, is he used to be, a little bit of context, he used to be the senior APT at Ipswich before he left. The issues that he was trying to fix and flag never got fixed, and so now here I am fixing it before I go to Yorkshire. So in terms of that responsibility, obviously I'm trying to tidy things up from my home mortuary at Colchester to make sure that, you know, all of the samples and the specimens that I've taken and need to go, you know, onward for further specialist analysis are sorted out. At the same time, I'm trying to give a locum an induction, ensure that they, you know, are aware of the systems of working that have changed since they were last an employee at the trust, which is a year ago. And then make a bit of a plan as well to get the post-mortem backlog sorted for the Suffolk coroner, because there's been such few. Essentially, I'm trying to remain very, very diplomatic when I say this, but the right people have not been in post at Ipswich, and that is abundantly clear. It's those interpersonal skills, it's that planning, it's that applying their methods properly, it is prioritising their workload properly. They've not been doing it. And so the workload has grown and grown and grown and grown and grown. They've all become stressed. They've all gone off sick with stress. I've been parachuted in from Colchester to fix it, and I've got my husband to come back as a locum. So a lot of it is very much looking at what needs to be done to make the service effective, keeping all the external stakeholders happy, so offering those visits to families where we can, getting the post-mortem work done so they've got the answers about what the cause of death has been. Again, any samples, toxicology, neuropathology, cardiac rehab, cardiac in the young studies, they all need to be sent off as well as keeping the coroner happy, which is really, really difficult at the moment because the coroner has had a year of being very, very unhappy with Ipswich, and I'm having to unpick all that. So at the moment, I don't necessarily feel like someone who's very junior in my career. I'm using a lot of my corporate knowledge from 16 years in the NHS to placate people, sort things out, make a plan, and act the plan. And actually, between Dave and I, over the last 3 or 4 weeks, even though we've both got colds, that's why I sound like I've been smoking 60 a day when I don't even smoke. the two of us have actually managed to turn it around completely. So we're on top of PM work. Samples are where they're supposed to be. All of the equipment is being cleaned and maintained and making sure that it's safe. So the oscillating saw that we use, for example, the trolleys that we use to get our patients in and out of the fridges themselves. So at the moment, it feels like we're doing all of these things to try and get Ipswich up to speed, but then we're both off next week because it's our wedding anniversary a week today, and so we've got a week off. We were going to go to Rome, but we've got to, be up in Yorkshire sorting some bits up there instead. And then
well,
I'm only there for 2 weeks and I leave. Thank
congratulations.
you.
Yeah,
we've crammed quite a lot into a year. So
yeah, so I think I need to check, but I think it is the end of next year that my wife and I have our 10th wedding anniversary. So I want to basically do something. Obviously, therefore, we've got our 9th coming up in 2 months. So I will mark it in some way. But I'm determined that for our 10th, that I want to do something big. Like, we generally never go away, and that's partly to do with our dog. But I want to try and see if it is possible to sort of mark our 10th anniversary in a more significant way, Yeah. I mean, sadly, they always say if you want to see an animal with a ridiculously good life, look at older couples that have never had children, because effectively the dog or the cat becomes like the child, and so they are spoiled. And we know that Bebe's a little bit spoiled, our husky, but that's how we want to live. Anyway, one thing I will ask you, Lucy, because we're obviously having a session today where we're talking about things that, in effect, you've gone through with your own RSci Tech, and you're also, moreover, an assessor. So you have experience of what to look out for. So I want you to tell me. I'm not sure what I can teach you today, if I'm going to be honest. I mean, we'll go through this, but in a nutshell, so I can think about maybe what I say as we go through the different competencies, and then we'll just end with the cap. What is it? So when you do your assessments, just remind me again, Lucy, are you assessing all 5 competencies or not?
Not at the moment. I've put myself in the pool to do that, but at the moment I'm just doing shortened route that's mapped against the qualification.
Okay, yeah. So in fact, I can already see that actually now I get it, and I think we've talked about this. So I'm not going to dwell too much, but because a lot of these things, particularly in A, so what I'm going to do is, and think about B, C, D, and E, because if you are looking at competencies for the shortened application, you're probably focused on A, aren't you?
I think it's more, let me think, because I've marked so many. It's B, D, and E.
Oh, right.
I think that we do. A lot of it is around
interesting.
Yeah, it's really, really, it's odd that they waived A, they waived C, and in fact it's not every standard. You're making a racket, sir. It's not every standard for B, D, and E either. They've again got rid of some of those as well. So when I say shortened, it really is shortened, but a lot of it is around process improvement, minimal supervision, stock taking, CPD, updating improvement methods, but there's not a lot around any sort of mentoring or anything like that. There's nothing around the sort of EDI stuff or the data protection or anything like that, because so much of it is covered in the portfolio that we do as part of our qualification.
Yeah. I tell you what might be useful, Lucy, for me is, can you send me details of what it is specifically, not for today, but just for my own education, what it is specifically that you're expected to assess, because maybe there's a paucity of those particular objectives within your working portfolio. Is that okay, Lucy?
Absolutely. I'm just writing an email to myself, but yeah.
Yeah. So in terms of what you assess, and perhaps why you're here today to talk through things with me. When you look at that whole list, are there things that stand out where you say, yeah, I assessed that and this is what this involves, or oh no, you know, I hadn't specifically realized that in terms of what I don't assess is in there. Is there anything that you want to sort of talk about, Lucy? I'm going to hand over to you. Normally I'd be a little bit more didactic and instructive, but I want to make sure that we talk about things that you want to talk about that maybe you don't assess. So if you want to start by talking about things you do assess and give examples, and then if you want from this list, ask me, think about things that might fit those examples there. And then if you want, and it may be that this obviates the need going further, but that you can say, well, Lawrence, actually I do this, how would this fit? Do you see what I'm saying, Lucy?
Absolutely. Absolutely.
So I'm going to hand over to you then and drink some water.
So what I can immediately see is that what I do assess, so a lot of it is around supervision or minimal supervision. So a lot of people will give me examples of, for example, if they're on call as a trainee, but obviously someone who's a little bit down the rabbit hole with their training, you don't get somebody who's fresh out of the box doing an on-call rota, where they might escalate, or if they're in the post-mortem room, again, as a junior member of staff under supervision, where they would cease a post-mortem examination or ask for advice or ask for best practice, or if, for example, they're looking through the post-mortem paperwork, we get through people's GP summaries, medical histories, we're looking for any sort of infection risk, anything weird and wonderful that we might be expecting. I had one when I was a trainee, somebody had a lung transplant, so I've never seen that before. What would I be expected to juggle within there when I get into that person? So a lot of it is around sort of scope of practice and escalation, or appropriate escalation, knowing when to recognise that you don't know everything, which is great. You know, nobody's ever seen it all in the world of APT, but your weird and wonderful things. You know, I was talking to Dave the other day. Dave's been an APT for 10 years. I've been one for 5.5, and between the two of us, we've done a handful of spinal cords because it's so rare. Yeah. You don't take out people's spinal cords normally unless they've got a previous injury, or if it's for a donation situation for research. Thinking as well with updating and improving methods and introducing new equipment, there's a lot around different ways of or different methodology you can use when you are reconstructing somebody. For example, if they've sadly died in a fire or been in water for a long time, what would you do differently? So a lot of it is actually around troubleshooting, and a lot of it is mainly applicable to the PM room rather than outside of the PM room. Just because that's the sort of most exciting part of our job, really. Everything else is paperwork and talking to the coroner. So a lot of people go for the weird and the wonderful things that they've seen. There isn't really a lot. I mean, we don't really cover A&C at all, so I'd be really interested to sort of speak more about report writing and data analysis. And in category C, I mean, I can think of examples immediately, liaising with specialists and non-specialists, because I've obviously been auditing a lot of practices at Ipswich since I was drafted in, and I can see that there hasn't really been the relationship with our neuropathology colleagues in Cambridge to, without feeling like I'm grassing Ipswich up, get their specialist specimens sent over in a timely manner. So I've had to do a little bit of networking there to make sure that we've got the right people in place to look at these specimens to get an answer for the families. And liaising with non-specialists as well, we could be giving tours to end-of-life care teams or military police or junior doctors. We could, non-specialists, you could even put the bereaved in there, because we're trying to guide them through the coroner's process or the certification process as a whole. I could speak all day about what I do, to be honest, but I can see where for the longer application, so the application that Dave's going to have to put in because he qualified so long ago, there's definitely applicable scenarios and situations that you can reflect on as part of it. But I think some people, especially if they're more junior, so if they really have, not even more junior, if they've only ever been in one place, working in one mortuary, and they're very contained in what they do. I can think of a few people that I know across the network like this, where they're not going to get involved in data analysis and report writing because there's a very strict structure, and it's very much a you shall not pass. So I think people might struggle with data analysis, report writing, and the whole specialist, non-specialist thing. Because even though I can think of an example, I've worked in 2 extremely busy mortuaries with a lot of, input from other centres to get us the results we need, because we don't do paediatrics because we're so close to London. So they go to Great Ormond Street. We don't do neuropathology or our own toxicology samples. So again, it is liaising with them to get the answers. But there's such a variation of what people are quote unquote allowed to do.
Yeah, and
depending on where you work.
What I'd say, Lucy, as well, is that this particular list, as we'll see when I go through the sub-competencies, and I'll get you to talk, but this particular list actually was taken from a talk where I was covering all bases, in other words, all registers. So clearly team leadership is not RSci Tech in terms of what you need to demonstrate. And that's also true of liaising with specialists and non-specialists. You mentioned non-specialists, the distinction between those two might be a problem. Well, as I think we'll discover when we break down C into C1, C2, C3, I don't think that's needed for RSci Tech. I should have made it clear before we talk through this, that this really encompasses all 3 registers. So you were saying, it sounds like, just remind me again, Lucy. So in terms of what you do in the mortuary and adapting methods and things, certainly for an RSci Tech, scoping and planning and bringing in new projects, let me just say at the outset, that's an example of CSci. And what's interesting with you, and let's just digress for a minute, is when I think about the fact that you're being, is it Ipswich that you're sort of getting sort of to try and comply with new methods because the coroner isn't happy? Is that right?
Yes, yeah. Or basically just trying to just get the service running, to be honest, which it is under Dave and I doing that.
So this is interesting because that's not even our side. That's CSci, Lucy. That is CSci. And so let's digress for a moment. Based on what you've told me in the past, your years of experience, because you have got 5+ years, haven't you?
I have, yeah.
Okay. Now, what is your highest qualification in terms of a bit of paper, Lucy?
I've got a degree. It is
so
a
you've got a
Bachelor
level
of
6.
Arts. Yeah, but it's
Right,
a BA, not a BSc. But
yeah, okay. But the thing is, there is equivalency, which basically is if you don't have the right degree, to make it inclusive, which comes into E actually, you can, as long as you can demonstrate in terms, let's say, of your own aspirations, your own charter, as long as you can demonstrate that you're working to level 7, and if you're setting up or making sure that a lab complies with what a coroner wants, I mean, unequivocally, that's not even RSci, it's CSci. So before we go on and try and unpack some things, I want to ask you a few more things, actually, just to get things straight in my head, so that what I say I feel is optimal for you going forward. But you're currently RSci Tech, aren't you?
I am, yeah.
Right. You don't have to become an RSci to become a CSci. What is stopping you, Lucy, with your years of experience and your extant practice that's quasi-managerial? Have you thought, is it possible within the framework of your job? Because I know of people that do what you do and they're CSci. Have you thought about applying for CSci, which is my last talk with Charlotte, because she's RSci, was mentoring her for CSci, and she's got tons And I think you have as well. So what is going to stop you, Lucy, do you believe, from becoming CSci? Have you thought about applying for CSci?
I hadn't until today, I must admit. I know that it's something my new boss in Sheffield would be keen to support because I'm going to be doing advanced practice and really, going for gold there. I mean, I could obviously bring in my experience from Colchester and Ipswich
Yeah,
to any
yeah.
application I make anyway. I don't have
Yeah,
to
you
keep
want
it so
really, you
narrow.
want five years of experience,
Mm,
but it doesn't have to be from the same job. I
yeah.
always say don't spread it too far. So when I put in my application for both RSci, which I realized was a mistake, I thought that because I haven't got team leader in my job description, that precluded me. It doesn't. It's about what you practice on the ground, not what grade you are, and therefore how much you get paid. If you're supervising as well as training others, if you're basically trying to ensure that the lab works to certain standards. And by the way, is it obvious to you that in terms of getting things to work at certain standards, that is competency D? Is that clear to you, Lucy?
Yes, it absolutely is because especially where we've got new standards that come in from the HTA, it's how we're
Yeah.
implementing those as
Yeah.
well.
So
Yeah.
there's your D. So and A really is about once those are all in place, what do you do to actually carry out those procedures day on day, whether that's you or people that you train or work with? Do you see the distinction?
Yeah, I absolutely do.
So it's
So I'm
day
just
to
writing a little
day in
note to
A.
myself there.
Yeah, it's
But
day
yeah.
to day in A, and maybe if you basically I'm trying to talk round things here to make it most relevant for you, Lucy, which is why I said that it's not a formal talk. It's trying to optimize it for you. But essentially, what I'd say is that A is about how you practice day to day, week to week, standard operating procedures that are already in place. If you move to a new method or a new standard, then you can mention that in A, but that really comes into D. And in your case, you're front loading because you're talking about going into a lab and getting things up to a certain standard. So that's really D. And then once you've done that, the people under your care or your colleagues will then carry that out day to day, week to week. So that's excellent. That's something you talk about in A. Is that distinction between A and D clear, Lucy?
It is, yeah. It
Yeah.
absolutely is.
Okay. So we'll come on to this, but what's your understanding therefore of competency B? We've talked about planning and organization. Tell me what you assess, Lucy, in terms of the standards, and then talk me through what your understanding of competency B is.
So with B, there's not really much around the sort of organisation of the day-to-day work or the week-to-week work, but there is around um not necessarily the supervision of others, but working with minimal supervision and
Yeah.
knowing when to escalate. Stock take and ordering, that's in there as well. There's nothing about mentoring or report writing, so that must
No.
fit with the
That's
higher
up at
level.
Yeah, it
Yeah.
does. Yeah, and the other thing is I need to change this list because I've suddenly realized that B2, we're going to go through it, and this might just really reaffirm what we're talking about now. We're exploring at the moment, and there'll be reaffirmation as we go through. But the one thing that I haven't included in this is B2. And to some extent it's about working with standards, and by that I mean cost or other standards on a day-to-day level. But I'll say no more because I think we're going to come across those as we go to other slides. So in terms of this slide, the delineation examples, is there anything that you want to pick up on, Lucy, with me before we move on?
I think we've covered it. I think we
Yeah.
have, and I think it's handy to know that this list is all encompassing, but then it's got my brain thinking anyway for my CSI, because if I
Okay,
can
I'm going to
answer
make you
most
an
of
offer
those,
here.
then
I
yeah.
think you're so damn good, Lucy, like Charlotte. I've got two what I consider to be exceptional RSci techs that are so exceptional that you're not RSci tech. I want to help you with your CSI, regardless of whether that's a formal mentoring session that David Cameron pays for or not, because I think that you've got tons of stuff. And the question is whether we do this as an extra session now or whether we wait until you're in position. In terms of Ipswich, you're moving to Sheffield, right? The project with Ipswich, is that something you're doing right now? Is that something that you're doing when you go to Sheffield, or will carry on doing it when you're in Sheffield?
It is something I'm doing right now. I'm not going to be carrying on. I mean, I'll be there on the end of a phone if they need advice and guidance. You know, I'm not going to the moon, so they can always call me. But it is something I've been doing for the last 4 weeks, and I will be doing it until I leave on the 5th of December. Just to get them over the line. And we had a recent HTA inspection at both Colchester and Ipswich, July time. And a lot of this has come out of we did have some shortfalls. That's part of the inspection process. It's how we learn from it, and it's how we improve from it. You know, I don't see it as a big pointy stick that we've been jabbed in the eye with. The worst thing we can do is get better. So it's employing a lot of those things that the HTA did find were lacking, getting those up to speed. But then at the moment I am, yes, so Dave and I are the only members of staff in at the moment, because there's nobody else there. There may have been a bit of a mass exodus. I don't know what they're going to do when I go, because I started just helping out with their post-mortem room backlog, just going in a couple of days a week and doing their PMs and then scooting off back down the A12 again, even though I live in Ipswich, so I can walk to work at the moment, which is great. And it became very clear that they were struggling. Again, they've been running on 50% staff for quite a long time, and now it is zero staff. Because
So
I'm
are
not
you
technically
clear?
employed.
Are you clear that in terms of what you're enunciating, Lucy, that this is quite nice material? We'll talk about the specifics of the different competencies, which, given that it's already 1:52, I think I'm going to be talking to you for about another half an hour. Is that okay, Lucy?
Perfect. Yeah.
Okay, good. Because some of this will just reaffirm, but are you clear thus far that what you're really discussing falls within the remit of competency D? Does that make sense to you?
Yes. Yeah.
Okay, so this is an example of really the three registers. So it's experiences from the last 5 years, and in your case, because you've got 5+ years experience from what, let's say, 1 to 2 jobs, you're sort of within the remit of CSI. But let me just say that for an RSci Tech, as you might well know, or should I say, when you go, let's rephrase this because it's about you assessing the complete application. So essentially, as we'll see, there are different sub-competencies, usually 3 for your A, B, C, and D. E is 2. E is basically data protection, EDI, E1, and E2 is really CPD. That's what it is. It's CPD. Okay, as we'll come on to. But you want to take, I would say, for the standard application, if you've got for if you've got for RSci Tech one good competency answer that basically shows that it's worked, outputs as well as inputs, that's enough. But I would say that you're stretching things a little bit. I've seen this in one application where they took one genetic technique. I don't know if you've heard of it because it did garner a Nobel Prize, called CRISPR, which is where you can engineer the genome, right?
Yes.
Somebody thought, oh, I'm doing CRISPR. And they gave that one example and they just recontextualized it for every single competency. And I had to pass it, but I did comment that it would have been better given that I'd seen the person's CV. As great and sexy as CRISPR is, which it is, and it's bang up to date in terms of genomics, they talked about other things as well. You know, they were trying to impress me by saying, well, look what I do. You know, I'm doing real cutting edge stuff that's just resulted in a Nobel Prize. And that's true. but I want to hear about other things they do as well. So I would say for RSci Tech, in terms of the standard application, you want one example, and if you can draw it from different working practices, great. Now, as I want to work with you, mentor you, as I've done with Charlotte for your CSci, I really believe, Lucy, that we should look at CSci in the next 2 months, and we'll talk more about this at the end. I would say give 2 to 3 examples, right? So we're talking specifically now about your own CSci application and not a general RSci Tech assessment, right? And generally what you want is about 1,000 words, and that's broken into your 3 to 4 subcompetencies. So as a rule of thumb, you want your application, your particular subcompetency answer, and we'll break this down in a minute, okay, to consist of about 300 to 400 words. So in other words, if you do the maths, if there's 3 to 4 subcompetencies for each principal competency category, A to E, probably A to D, I think E stands alone, and we'll come back to that at the end. About 1,000 to 1,500 words, Lucy. Yeah?
Perfect.
Okay, right, let's move on. So, I'm going to ask you, because you're already assessing, I'm going to get you to look at those, and I'm going to ask you as an assessor if these are the sorts of things for the limited numbers of competencies that you look at. Now, defining acronyms and going easy on technical language, that might not apply to you, because am I right in thinking that for your niche area, only anatomical pathology technicians would look at anatomical pathology reports? Is that true?
Yes, yeah, that's right. So their jargon is my jargon, so
yeah,
I can use as much as I want.
Specialist communication.
Yeah.
So I'm basically not laboring things. Does all of that sort of tally with you in terms of your own application and what you look for in the subset of competencies that you assess for, putting aside the last one, which is maybe less relevant because it really is technical language that's your language? Does that all make sense to you, Lucy?
It does. That's exactly what I ask people for whenever because we've had a couple of workshops at the AAPT with Christian, and that's exactly what I ask people for, essentially.
Okay, so before we move on to the particular subcompetencies for all of them, which I think is maybe the best bit for you, are you familiar with the STAR sort of acronym? You may, yes, you are.
Yeah.
And what I normally say to people, I don't know if you look for this, but in terms of answers, identify the situation. The opening gambit can be about, is really about how a pertinent situation that fits the competency mission statements that we've identified, or we will identify more in the subcompetencies as we'll go through. Okay, so it's really setting the scene. Why is it that we've chosen this example? Then really 2, which is action, is explaining why it is that you do things, and perhaps if there's an optimal way of doing things, and this for instance feeds into A2 where you're selecting a method. Okay, why that particular standard operating procedure? Why have you chosen that? And then 3 is how can you say that what you've done is effective, whether that's a technical thing or whether in competency C it's effective communication. What is your yardstick for measuring that? Does that make sense, Lucy?
Yes, absolutely. Yeah.
All right. So I always say 3 paragraphs. In other words, if it's 300 to 400 words, approximately 100 words for a paragraph, although I imagine that basically paragraph 2 would be your biggest section. So that, maybe a few, maybe 3, maybe, 100 for 1 to 200 for 2, 100 for 3. Does that fit with you, Lucy?
It does. Yeah.
All right. So that's situation, task, action, result. So let's go on to the actual subcompetencies and hopefully identify things that you haven't covered in your limited assessment. So I'm assuming, so these are the knowledge statements for the 3 sub-competencies subsumed by application of knowledge and understanding. So take a look at that, Lucy, and let me know if you are familiar with this.
Yes, absolutely.
Okay, so A1, do you assess competency? You did say that you don't specifically assess competency A, do you, Lucy?
No, but these are ones. So what before the shortened route came in for APTs and RSci Tech, I started my long one. So I started answering these.
Okay, so I think, to be honest, Lucy, we've sort of covered these by having an open conversation, but essentially in A1, you need to give examples of things that you do. So this is really techie talk. So it is about either it's about applying your knowledge in a day-to-day working environment. So you've got to give examples with an explanation of the science. Okay, what is it that you're doing? And what is the science underpinning that? Okay, that's really what A1 is. So as it says here, I've got the actual ones here. So application of knowledge and understanding. So the your opportunity to demonstrate your scientific knowledge and understanding and how you apply it in the workplace. So that's A. So A1 is basically, I'm reading the sort of summary there. You should name and describe in technical detail how you use the main components, elements, materials involved in your work, involved in carrying out a procedural process, involved in using experimental monitor or computer program. So it doesn't have to, and the idea with that is that there are bioinformaticians, and sometimes things that you do are computer based. They're not necessarily, well, in your case, they're not in a lab, but let's talk about that a little bit. So given that you don't assess that, in terms of things that you do that demonstrate application of knowledge and understanding, the application of technical knowledge and understanding. So A1, okay. What would be an example of something like that with you, Lucy?
So straight off the top of my head, it would be preparation of the patient, myself, and the PM room for a high risk case. So we're not super computery, but that's where we would receive the authorization for post-mortem from the coroner with the medical history, look through it, where are our risks, what do we need to do differently, what additional infection control procedures do we need to employ, who do we need to inform about that, how do we work differently, how do we take tissue differently. So that's where I'm immediately going with it. I'm thinking of a high risk bloodborne disease, for example, that somebody's got. How will I employ my knowledge of that pathogen to work differently, get a good result, keep us all safe? That's it in a nutshell.
What sort of equipment are you using to do that, Lucy?
So it sort of mainly boils down to sort of PPE. It may be that we use a different set of instruments in the PM room for dissection of the organs, just to ensure no spread of pathogens. It will be use of visors and respirators if that's an airborne disease rather than a bloodborne one. So again, it's mainly sort of around our PPE and processes. It could be that we use a completely different oscillating saw for that, one that is kept purely for high risk cases. How we decontaminate that afterwards using our I call it the dishwasher. It's not a dishwasher, but it looks like a dishwasher. Our washer disinfector. I always get the dishwasher's on. So yeah, I think it's that whole sort of process around high risk cases. We did have a case recently actually that was we were treating them as a Cat 3 airborne disease because we didn't actually know. We knew there was something wrong, but we didn't know what. We didn't have a name. So what we do around that and how we keep everybody safe as well.
Okay, so yeah, I think as well, because there's a lot of overlap between A1 and A2. And A2, when I look at the actual detail it says here, review and select scientific techniques, procedures, and methods to undertake a task. So you can explain the underlying reason. And to sort of add to that, because obviously this is just a summary. So if you look at the unexpurgated competency mission statements, it says, for example, the principles behind the activity that you are undertaking and associated technology. So in that sense, it's explaining the science for what you do, similar to A1. And then the key difference is the reasons behind the choice of your method. So what I want to try and do now, in your case, Lucy, is try and elucidate a situation where you would use a standard technique, let's say for A1, but I think what you've sort of explained is as much A2. So give me an example of a run-of-the-mill sort of thing that you do, equipment, STEM practice-wise, that would fit A1, and then just go over again where you've got something that's slightly different, so you think, aha, maybe that method's better than that. Do you see the difference that I'm making? I'm trying to actually get you to think about how you'd answer A1 versus A2. So if you want to fire away then, Lucy.
Oh, absolutely. So I'm thinking of a completely different scenario now. So I'm thinking of where a patient may have meningitis. So a completely run-of-the-mill suspension of somebody's brain for specialist neuropath analysis. You're still PPE'd up, you're using your oscillating saw, you're suspending in formalin. Jobs are good and you wait 2 weeks for it to fix, you drain it, you send it to Adam Brooks. They can tell you what was up. Brilliant. That's our regular we're sending a brain thing. For a brain with meningitis, we would use a completely different saw. If we're using the oscillating saw at all, it could be a hand saw. It could be that the chemicals we use to decontaminate have a longer contact time.
If you were to basically put that in an assessment, you said you use a completely different saw. You're obviously just telling me, but you know that in your method, in your answer for A2, you'd have to explain why you use a new saw. So why would you use? Tell me why you use a different saw then, Lucy. What's the rationale behind that?
You would need to ensure that, because this is a high risk case, that you're using completely different equipment to stop any cross contamination.
Yeah.
Or if you're not using the oscillating saw at all, it's the same kind of saw they use to take off plaster casts in the wider world. Or you'd use a hand saw to ensure that you could decontaminate it effectively. You're not having any kind of cross infection, even down to the way in which we would fix that tissue afterwards. You would do it in an isolated space. You wouldn't just do it at the end of the PM room near the downdraft table. You would ensure that at every step you are containing that potential pathogen to stop the spread of it. It would have to fix for longer in formalin, just to ensure again that there's no risk of infection at the other end when they receive the tissue sample.
Yeah.
So again, it's that kind of it's a chain of events I'm thinking of. I'm just thinking sort of a more dynamic risk assessment, really.
Yeah.
But yeah.
No, I think you've answered. Okay, so having done a sort of more routine thing in A1 or reflected on a more sort of niche method for A2, how do you know, having gone through that practice of STEM, that application of practical knowledge and understanding? So A3 is about what comes out at the end. How do you know it's worked well? Okay. How do you interpret and evaluate data in your context? Give me examples, because I'm so lab-based. It's easy for me to think about labs. But give me examples, Lucy, as a successful and experienced practitioner, of how you can tell if what you've done in A1 and A2 has worked, and examples of when it's not gone as well, why it hasn't gone as well, and ergo, what do you then do?
Absolutely. So for the quote unquote bog standard fixing the brain before it goes off, if you don't fix it for 2 weeks, the tissue deteriorates. You don't get a good result under the microscope. You're not going to be able to see any cell changes. You may not be able to get a cause of death for that patient.
Yeah.
So that's very much a very knock-on effect there. With the meningitis case, again, fixing it for longer ensures no spread of disease, and no sort of no risk of exposure to that pathogen. So as awful as it sounds, it might sound quite flippant. You know, it's gone well because nobody gets sick.
Yeah.
But essentially, it is that sounds quite flippant. I'm thinking about my heart cases. So if someone's quite young, they've died quite suddenly, we will, without dissecting the organ, we will suspend and fix the whole heart in formalin, so buffered formaldehyde, for 2 days, along with a piece of spleen, which has an enzyme on it to help break down the tissue, so they can look at genetic material from the spleen to look at any risk to future generations of any sudden cardiac death or any sort of underlying disease that the deceased didn't know about. Unfortunately, one of the things that I've had to fix at Ipswich is tissue not being fixed properly for specialist analysis. So again, when that goes wrong, these families aren't getting answers. That in itself is not very scientific. It's the more sort of, we bridge a funny sort of world between science and healthcare. It's really, but essentially, we can't get those families answers. We can't advise if they need further testing themselves on the living, see if they are gonna sadly have the same disease, if there is a congenital disease there that the deceased didn't know about. So again, that's something I've had to fix. I did an audit of tissue and it wasn't great. It really actually genuinely really upset me, because all I could think of is at the end of this, these families aren't getting the answer that they need because whoever was in post at the time wasn't doing what they'd been trained to do properly. Cause and effect there. But yeah, it's essentially, especially with the cardiac risk in the young, the CRI study, where you do send the heart and the spleen, yes, it's to establish the cause of death. That's 101. That's why we're in the post-mortem room. But there is that knock-on effect to future generations. Like, right, what can we learn from this to help keep their relatives safe, to make them aware of, the treatment they might have to access because they don't want to end up, in my mortuary at the age of 40, having died suddenly at home. So, it's the knock-on effect. But I feel like I'm really going down a bit of an Ipswich rabbit hole. But that's been my life for the last few weeks. It's been finding out what on earth's been going on and fixing it.
Wow.
So,
yeah. As I say, that really lends itself more to CSci. This is really a summary of, when we say what examples can you effectively, we've gone through them. So you happy with that delineation between your A1, A2 and A3?
Yes, absolutely. Yeah, perfect.
Okay, this was actually something that I took from an anatomical pathology RSci Tech talk. Now, when you look at this, does it seem familiar?
Yes, absolutely it does. I mean, that is a beautifully fancy theatre that you've got. The PM rooms don't look like that, but I enjoy that a lot. I like that a lot. But yeah, with the process improvement as well, risk assessments are a huge thing. I mean, someone said it. I'm part of the APT council now as well, and they were laughing at me because apparently I'm always dynamically risk assessing something. I'm like, I don't want to sit there during the council meetings. I'll get a crick in my neck, and they do giggle. I am the dynamic risk assessment queen. But yeah, equipment organisation as well, fantastic. The last thing you want to be doing is trying to open new boxes of blades and things whilst you're trying to deal with a post-op patient. Again, protocols, codes of practice, the Human Tissue Authority, perfect. And yeah, your workstation setup as well. People have different ways of working. I even spot it in my husband because I haven't worked with him for 5 years. Again, seeing the way he works in a PM room and different things that he'll have available to him that he thinks he might need are different to what I think I might need, but there's always logic behind it and there's a thought process behind it, and so that's really interesting. But yeah, these themes are all very familiar to me. But yeah, I wish I had that theatre lighting. That's gorgeous. But yeah. So that's really sad, isn't it? I really want that light.
They've obviously created the perfect theatre for their for their little sort of pictorial illustration.
It's beautiful.
Okay, so what I've tried to do here, based on those examples I've given you, where it can fit different, I believe, can fit the different subcompetencies of A, is these are examples of A1, A2, and A3. So I'm just going to ask you, Lucy, because you're the technical expert, if you were to pick examples of day-to-day practice in a technical sense, does all of this ring a bell to you?
Yes, absolutely it does. I think, again, it depends on the type of APT you get when it comes to method critiques and literature reviews. Like there needs to be a work on the culture around that, I think, but in general terms, yes. Technical documents, absolutely. Health and safety is the biggest thing we do.
Because that's the
Modification
one
of
thing I want to
samples,
stress.
yeah.
It isn't just about it isn't just about practical. It isn't just about practical knowledge, practical practice, okay, with your equipment, let's say in the morgue, you know, your monitors, setting it up, etc. It's about the sort of processes, including documents, associated health and safety, that's going to be enormous in your area because of what you do. You'd be under such public scrutiny. This is all application of knowledge and understanding. So do you see that full gamut of what application of knowledge and understanding is?
Absolutely,
I'm sure you do.
Yeah.
Okay. And I'm going to ask you the same for A2, which is about does this all, because there is a big overlap between A1 and A2, okay, and A2 is about maybe selecting a particular method. So not surprisingly, these diagrams are the same, but it's maybe explaining the fact that you making it clear why you picked a particular method in the case of A2. Does this all, I mean, forget that first one, that's really that's growing up bacteria, that's a lab, but it's trying to illustrate protocol adaptation. So in your own world, Lucy, does that sort of make sense to you?
Absolutely, it does. Yeah.
And
that finally,
evaluation of data. Okay. And it can also be, by the way, let's go back and look at this, because in terms of what you can write, I'm just reading the small print of the that's the other thing actually I didn't really stress, which is it isn't just about recognizing good data and therefore what you do with it or don't do with it. It's about how you present that data in the most optimal way. So in your sense, based on what you do, are there particular sort of presentation tools or ways that you would communicate the data you have? I mean, I'm sure that there are probably standard procedures in your sort of highly visible healthcare sort of profession about ways that you present data. So I'm just getting you to try and sort of think about and expand upon not just how you recognize good data, but the tools that you use when you evaluate that data, and maybe the tools that you'd use to present that data to colleagues. So do you want to just talk round that a little bit, Lucy?
My immediate thought is our quarterly reporting to the coroner, both in Suffolk and in Essex, depending on which hospital I'm at the time. But I don't think I'll be back at Colchester now before I leave. So a lot of that is around. It's very sort of dry. It's more sort of around sort of turnaround times, how we're meeting the KPIs that we have set up with the coroner. how we're meeting their expectations or not. And so there's very sort of distinct parameters around what their expectations are and how we meet them. And also, if we're not meeting them, what are we going to do to comply? Obviously, with the most recent HTA inspection, we get the corrective and preventative action report through. And there's a weekly meeting with them at the moment every Friday on the back of that, just to see where we are with compliance. And again, it's the agreed milestones and time frame that we have with them to see, again, what needs to be worked on, what the priorities are, what the risks are, what happens if we're not compliant by the deadline. So yeah, there's a lot going on with that at the moment. And again, it's where we get our data from as well. We have a sort of centralized database that has all of our patients on there, and when they had their PM, when was it requested, when did they come into us. There's a lot that goes on in terms of auditing, as well as a whole audit schedule. So there's an absolute wealth of things that I could have for that easily.
Wow.
Easily.
And just to sort of make one more delineation, I'm really trying to sort of drill down into the details here for you, Lucy, so we can discuss around it and you've got something in a recording to refer back to. But I'm just looking as well at the fact that in A2 you can select a method from something more complicated or niche, and then in A3 it's about recognizing the data. So it says if the activity has failed, what do you propose to do next time? So it ends by saying you might find your answer in A3 is an extension of A2, demonstrating how you solve the problem described in A2. So what it's sort of alluding to is the idea that what you do in A2 is almost a little bit of troubleshooting in terms of a method you select, because there are particular concerns. But if you don't meet the required data standards that you recognize in A3, what do you do to mitigate that in terms of a repeat analysis or next time round? So give me one particular example of that, Lucy, that you would talk about in A2, but perhaps you've identified that the data isn't quite right in A3 as part of your data evaluation. What would you do next time? So give me an example of that, Lucy, before we move on.
So drawing on the example I gave around the sort of fixing of tissue to go away or the fixing of a brain to go away, if we are unable to get any sort of meaningful cell change off the back of that, nothing can really be seen under the microscope, the tissue hasn't fixed properly, could we experiment with the concentration of formalin we're using? How long do we fix for?
Yeah.
Do we fix it in a different way, different environment? Do we keep it refrigerated rather than just, fixing? So again, there's a lot that could be done around it to see what actually is going to get the best results for us to see, a decent slice of tissue under the microscope, to see those changes, to see what we were expecting to see but haven't seen.
Yeah. Okay. Yeah. So these almost repeat one another, but these are the summaries of the actual extant current subcompetency statements. So I'm sort of cross-referencing this with the actual more detailed things. So B1 is about how you plan and organize the different components of your job. So let me start by getting you to think about what are your principal responsibilities. When you plan your time, when you sit down and you think about how you're going to plan your day and the different types of activity, give me a sort of distillation of the sorts of conflicting or consonant things that you might have in your day in terms of practice, paperwork, etc. Try and give me a sort of summary, Lucy, of what you do. I mean, maybe there isn't a typical day, so just give me sort of a flavour of that.
Absolutely. So a lot of it will be get the patients out for post-mortem, get their IDs checked, get any different kits we might need for them. If they need toxicology, let's get a tox kit out on the bench. Let's get histocassettes written out. I'm thinking of tomorrow morning when I walk in, it's like, right, there's a sample to go to St. George's at 7 a.m. There'll be all the weekend patients to put on the system, book in, condition checks, implant checks, infection risk checks, check. All the patients that we took tissue from last week, is there a decision around what the family want to do with that tissue? Emails, phone calls, does anybody want to come and visit their loved one? How many collections have we got? Who's going to go out to their funeral director? Do we need to freeze anybody who isn't in a great condition? Yeah, that's my Monday list. That is my Monday brain. Like, what are we going to do? There are no postmortems tomorrow, though, because I've done that on purpose to give us a decent crack at the week.
Okay.
So yeah, there's nothing booked
I'm
in
going
for
to give
that.
you a summary here of what it talks about for RSci Tech in generic terms for the overall 3 subcompetencies that we allude to here. So it talks about crisis management. I'm sure you've got many examples of that. Lab, or let's say mortem, post-mortuary team organization, maintaining quality outputs, health and safety responsibilities, and sustainable practices. We'll come back to that one in a second. That's an interesting one. But if we look specifically at B1, it says work consistently and effectively with minimal supervision to appropriate standards and know when to escalate. So in terms of your own sort of working day and the different attributes, the different responsibilities, how do you identify, or how do you practice in such a way, Lucy, that you work independently, and examples of when you know to escalate appropriately, and to make a judgment on when to escalate? So this is reference to your personal responsibility rather than interpersonal skills, which is a focus obviously in the next group, in other words, competency C. So what does that mean to you, Lucy? I mean, you may be repeating yourself here. I'm just trying to sort of get you to reflect upon the different subcompetencies and what you might look for in a standard assessment. Okay, so do you want to talk through that then, Lucy? And you can repeat things you've already said.
Honestly, this is one of the ones that is part of the shortened route anyway. So I've seen some great examples for this one, but for me,
Okay.
I'm thinking of last week. There was a gentleman who needed a post-mortem.
Yeah.
We got him on to see Dave and I got him onto the post-mortem table ourselves fine because he was in a body bag and so he was easy to laterally transfer. However, this gentleman was 30 stone. Actually, I think he might have been more than 30 stone. And so there was a discussion around we're not going to be able to get him off here safely. We need to call the porters because I think the porters out of hours will transfer patients down to the mortuary, transfer them onto a fridge tray and put them away. So their manual handling, they've had the same manual handling training we've had, but we recognise that actually he's 30 stone, it's not safe. Neither Dave or I are built particularly big. So put in a call to the porters. Can you send 4 big strong boys down, please? We need to help get this gentleman safely transferred off back onto his tray. We need to maintain his dignity. Within 5 minutes, we've had some porters come down, which is again testament to mainly Dave because he was there for so long, the kind of rapport that he has with people to get them to help. But again, it's recognizing that had we attempted that on our own, it compromises our safety, it compromises the patient's safety. By getting the right people involved to help us with that, he was very, very safely transferred over, really respectfully transferred over. And then we got him nice and in his gown and back in the fridge. Or a lot of it's around capacity. When I was a trainee, I worked in a mortuary that was half the size of Ipswich, but covered the same geographical footprint in terms of the community deaths that would come in and the hospital deaths that you'd get coming in as well. So you had to be on top of your fridge space. And there was one day in December, and there was that many inpatient deaths that we very quickly went from having 40 spaces to having 7 spaces left. And when we got to about 15, I sort of said to my senior, like, this, we need to do something about this because we're going to have no space for the weekend. What do we do? Because as a trainee, I was like, right, I can obviously we need to take these patients in and book them in and find them a space, but if this rate keeps continuing, we're going to have nowhere to put them. So then, yeah, she is my senior APT, then made the call to have a hold on any community deaths being brought in. So we just got the hospital ones,
This
just
is
to save
brilliant
a bit of
because,
space.
I mean, basically, this is about autonomous working,
Yeah,
meeting deadlines, in other words, planning. But what you're
yeah.
talking about is escalating, taking advice. What do you do? Okay. I mean, these are fabulous examples, Lucy, that really exceed RSci Tech. You know, I mean, you're giving me essentially the mission statement of RSci Tech and then some, which is why we maybe quite soon we should start a conversation about, I don't think even looking at RSci for you, but looking maybe even at, as I say, Seaside. But so B2 and B3 about maintaining quality output. So if I read you B2, risk assessments associated with your work, relevant health and safety regulations, manual handling, you've just mentioned this, home office stuff, safety training courses, safety equipment and control. I think that just based on what you've said, you've talked about a ton of things. So you would have no problem, would you, Lucy, either writing about that or assessing it?
Absolutely no problem
Yeah.
at all. It's our bread and butter, so
Yeah, exactly.
absolutely.
So I'm not going to dwell on that, but let's go to B3, which is interesting because, you know, you've got your bread and butter is risk assessments, manual handling, home office licenses. And what you do is you'd look to make sure that the person specified what they are and what the rationale is. That's what
Yeah.
you want in your answers. But what about taking responsibility for the quality of your work and impact on others? So this means that you can describe how to take responsibility for the quality of work that you undertake and its impact on others. So, for example, ensure that this activity is carried out to an agreed standard. And I've mentioned ISO there. Um, Point out good experimental data and bad experimental data and the reasons why bad data might have occurred. Okay, so that's about knowing what to look for in terms of working for a standard, or if you have to follow different levels of regulatory frameworks, e.g. company government regulations, and the differences and how they impact on your practice. So give me examples. You've you obviously have to work, did you say, Lucy, under the auspices of the Human Tissue Act because of what you're dealing with?
Yes.
So there's a ton of stuff you could put in there. So we that's a given with you. I mean, you do it probably far more than me. What other sorts of regulations, just out of curiosity, as someone that's not in your field, do you ever look at things like, it may not be possible, but for instance, I've just been involved in getting a sustainable laboratory award, silver grade actually, accreditation of LEAF for a lab I'm associated with. I know that in terms of quality control for very, very prescriptive processes that come under sort of that come under, you know, scrutiny, where the data is really important. And in terms of consistent data, there are ISO regulations. Do you just want to talk about regulations that maybe aren't specifically risk assessments, health and safety, manual handling, that sort of thing? What else do you do other than HTA? HTA, you are an exemplar of that. So think of other things that you might do, Lucy.
So whilst I've never worked for a mortuary that is ISO accredited, because every mortuary I've worked for has been divorced from the histolab. However, there are still things that we need to do to make sure that the lab is hitting
Yeah.
ISO standards. So when we take sections of lung, for example, if someone has asbestos exposure or mesothelioma, we need to make sure that, again, we're taking the right amount of tissue, it's in the cassettes properly, it's fixed for a certain amount of time before it gets to the lab, goes through cut up, the blocks and slides are all made. So again, if we don't do that, or if we don't fix our tissue, we don't get a result, because that tissue deteriorates, it decomposes, there's nothing to see when it gets to that point. So that means that the lab isn't able to uphold or hold what they need to do, but ultimately we haven't done the right thing to get the answer for the families or to get the result that we need, especially when it comes to asbestos cases. because it needs to be fixed for the right amount of time. There was a colleague I had in Colchester who was. This wasn't an asbestos case, it was a forensic post-mortem. There was tissue taken at post-mortem for blocks and slides. It stays with us until somebody from the police picks it up and takes it to the forensic lab, so a private company. And they didn't put any formalin in the tissue. And they couldn't analyse it. They couldn't get a cause of death.
Yeah.
So ultimately that's what we're bound by. But our big one really is the HTA.
Yeah, of course.
But then it's obviously health and safety practices around that as well. But the HTA is our big one, especially not being UCAS or ISO accredited. But when I work in Sheffield, I'm going to be working under ISO and UCAS accreditation as well. So again, it's meeting those standards about you do things in a certain way, and this is why, and this is the timescales that we need. So I think I'll be able to make that a little more interesting and a little less HTA centric once I'm at Sheffield, because there'll be far more to play with.
What I'd say is that in general for B2, most people do. Oh, sorry. Yeah. Yes, but I mean, what I'd say, Lucy, is that given that you know that everything, all roads lead to Rome. HTA is central to what you do. That is something that you should talk about because it's fundamental to what you do. But if you liked, because there's no reason to include a second example, but in effect, what you could do is include a second example, or you may come across one in your own assessment, and it may sort of refer to other things as well. What I'm trying to do here, Lucy, is get you to reflect upon different standards pertaining to your practice that people could talk about, or perhaps you going forward could talk about, let's say in a CSI application. Okay, this is really more for you now. We're sort of talking through these in real time, but what the Slido does is give you the ability to look at B1, B2 and B3. And if you like, we can go over those again. And then you can, by logging in with this QR code or going to slido.com, you can put examples. The reason I say this is we've talked through it and you're very clear, but do you want to actually go through this, Lucy, so that you've got a record for when you come back and look at this? So it's up to you whether you want to go through the Slido poll or if you're happy with what we've just talked about. What do you think?
I think I'm happy with what we've covered. Yeah,
that's what I
am.
thought.
It'd be good to reflect on. Yeah.
All right, so let's go straight. Oh, one thing actually I do want to ask you about is, so when we look at just making sure I've got the right pages here. Sorry, Lucy, I'm just pausing for a second. Yeah. B2, demonstrate how you apply safe working practices. Yeah, so another thing to consider would be lab recycling policies. That's going to be limited, I guess, when you're dealing with patient samples. Safe use and disposal of chemicals. So waste disposal, I mean, we know that in a lot of what you do, a lot of it will go to designated incinerators. But what about safe disposal of chemicals? Okay, waste disposal of chemicals, etc. Just before we move on, just talk a little bit about that and what the policies are regarding disposal of patient samples in terms of incineration, etc. You're going to have very exact protocols, and any sort of lab recycling, any sort of recycling that you may do in your area, it may be none. It's what fits you. So do you just want to talk me through that a little bit for the record, for the recording, so that you've got this in your own words before we move on?
Absolutely. So recycling, sadly, there is none.
No, not a lot. I wouldn't have thought.
There is none. I'm ashamed to say it. But in terms of the sensitive disposal of tissue. So again, that leads back into the HTA around the consent and traceability of samples, where people choose to not have them repatriated to Grandad, for example, or retained as part of the medical record or retained for research, they can be sensitively disposed. So there's a whole paper trail behind that, and then how we do that. So they're not just chucked in a clinical waste bin and hoofed off to the incinerator. There's actually they're appropriately packaged, collected, how we then record that on our database to say that the samples have been disposed of as per the HTA wishes. There's a big old audit trail around it as well as how we do it safely. In terms of chemicals, now when I'm draining the formalin off an organ to go to Adam Brooks, for example, or to St George's, I wish I could say there was a proper sluice in Ipswich post-mortem room, but there isn't. But again, I can talk around how I will make sure that my exposure to that chemical is kept to a minimum with the PPE that I wear, with the sink that I will do that in, with the downdrafts and the air exchanges that we have to make sure there's no particles remaining. So there's still things I can talk about around that, even if the actual process itself isn't optimal. I can talk about what we do, why, minimizing any risk, and how that's all recorded.
Okay, brilliant. Right, let's get straight to C and some of this. So that's in a nutshell is effective communication, interpersonal and behaviorally working effectively with others. In other words, what constitutes good teamwork? So if you look at the more extended blurb, so who might you communicate with day to day? And we've already talked about this. How do you communicate and when? And that can be the tools, email, presentations, etc. And what are good working? Why are good working relationships important? And what happens when there is basically a disagreement with someone? So let's move to this and have a look through this in a second. Forget that because this is probably all, I don't know how much of that is. Have a look anyway. But it's got here, competency C is looking for evidence of your interpersonal and communication skills and why and how they are appropriate and effective. So how do you define what's appropriate and reflective? There is scope to critically reflect on these skills. So the three competencies address the following: leading meetings, giving presentations, working with regulators, and working with line management. So if we go to C1, what we are looking for here is an example of effective communication. Okay, the example can be through oral, written, or electronic means. So demonstrating effective and appropriate communication. So I've got here how you discuss and agree objectives with your supervisor. How do you discuss and agree objectives in team meetings? How do you describe or present your work to your supervisors or colleagues? And that could be things like PowerPoint presentations, Teams. How you prepare written reports on your work, how you train students in the use of equipment or processes, how you demonstrate the process or system, the part that you play in the induction of new staff. So this is really different aspects of specialist communication that actually for RSci Tech, they're more interested in. So do you just want to talk me around that, Lucy? I mean, you already have, but go back and talk about things you've already talked about. You know, look at that, look at what I've just said, and then, you know, really talk around that, Lucy.
So again, it's for me, a lot of it is around how you alter your communication skills depending on who you're speaking to as well, because we've got the coroner, we've got the medical examiner's office, we've got fellow APTs, we've got the big senior leadership team who are obviously very interested in what's going on at Ipswich at the moment or what hasn't been going on at Ipswich at the moment. You've got the bereaved, you've got funeral directors, you've got all these different stakeholders, and it's what they need from you, it's what you're able to effectively convey. The language that I will use to the coroner, for example, or my fellow APTs is not the same language I will use to a family because they need a softer slightly softer approach from me. They don't need the very sort of black and white scientific, this is what we found in the PM room or whatever. They need a little bit more they need a friendlier sort of tone. They don't just want the bare bones of it. So and again, with the PowerPoint presentation that I gave to my peers at conference in September, again, the language I used there is very different, and how I went about that was very different. Planning, what do I want them to know? What's my data? How can I make it make sense? And then how can I just shoehorn it into 10 minutes? So it's all of those skills. Often I'll go through and draft things and then redraft things just to,
and
just
obviously
to make sure it's hitting the mark.
When you're talking to like-minded specialist colleagues, let's say at a conference in PowerPoint, it's going to be much more sort of technically laden with specialist terms that you presuppose that if they're sitting there, they'll understand because they're specialists like you. Whereas when you talk to a coroner, I'm guessing that's going to be some sort of word report, isn't it?
Yes, yeah, it really is a
what
lot of that
sort of things, if you think about the difference between what you'd want to convey to a specialist colleague in a technical report in Word or orally via PowerPoint in a presentation, when you basically talk to a coroner in Word, what is it that you're trying to convey and how is it different from talking to your specialist colleagues? What sort of things do you include and what sort of things do you leave out when you talk to a coroner versus maybe not so much training as talking about the results or progress, let's say, with like-minded specialist colleagues?
Essentially, I'm far less technical with a coroner or a coroner's officer just because they have very rarely even stepped foot into a mortuary, let alone know what may or may not be involved. I don't use terms like fixing specimens and things like that. I use words like preparing an organ to go away. It's far more accessible language that I'll use because then I'm very aware again that whatever I say to them, if they have a conversation with a family, they're going to be passing on as well. So I think about who they might be conveying that information to on the other side. With my, when I'm training people, again, I try and in the very early stages avoid the very, very technical level of communication because they're still very new to it. They're still absorbing it. I'll use a lot of analogies, and then sort of as our training goes on, I will start introducing more technical language as they're ready for it. I used to give a presentation to the medical examiner's officers at Colchester when they were new, and I'd run a report, get them the 10 most common causes of death from the previous year, but I wouldn't get technical with it. I go, right, if you say that to a family and they go, well, what's that then? Use this analogy, or this is what that means, or this is what causes that disease. So I just try and limit my use of jargon with different people if I'm aware that it's not their world, or I'm aware they may be passing it on to somebody who is not au fait with the kind of words that we use. I do find that I'm a better written communicator than I am an oral communicator. I've always been like that. I find it easier, or my brain finds it easier to speak to my hands rather than my brain speaking to my mouth. But that's just me. That's something that I've found even at school. I could write down whatever you wanted, but in terms of trying to verbalize something, especially off the cuff, I can't always do it. I think I'm getting better.
It's not coming across now, Lucy. It's not coming across now at all. So I would never have guessed that. But okay, I mean, once again, yeah, you're clearly on the ball. You've clearly got a lot of material. I've got to ask, Lucy, because really we're talking around things here. So before we carry on, because we've probably got about another, it's longer than I thought, but I don't mind, which is why I said it for Sunday. It depends on how much time you've got. We've probably got about another 10 to 15 minutes. Is that all right?
That's perfect. Yeah, no problem. Derek will wake up at that point and ask for his tea.
But in terms of how this is going, because obviously we're coming on to competency D, we'll talk a little bit about E. There's not so much to talk about. and then we'll just do a little bit about CPD. Has this session thus far, let's do a stock take. Has this session thus far, in terms of the discussions we've been having, the material I've been presenting, has it been useful to you?
Absolutely. Absolutely it has, because it's fired up bits of my brain thinking about CSci now as well. So I'm not just thinking about it as how I present it to people. I'm like, right, how would I answer that at CSci? And so
Brilliant.
it's
and I
really
think
coming together.
Yeah, and I think this was going to be our last session for now, but I actually think that while the iron's hot, Lucy, that we should do what I did with Charlotte, and I might even just take Charlotte's presentation and tweak it a bit for you and mention that to David and see if he's happy. Are you happy to have another session with me, which would coach you, get you thinking around CSci competencies? Are you happy to do that in the near future, Lucy?
Yes, please. Yeah, I'll be
Okay.
delighted to. That'll be
All
fab.
right. Can we do that on a Sunday? Because I'm always awake and
Yes.
we can speak for longer. Brilliant. Okay.
Absolutely.
So we'll talk more about that beyond today. So C2 is about demonstrating effective interpersonal and behavioural skills. This means, as it says there, you can demonstrate skills you to interact with colleagues in a constructive way, and it's how you define constructive within a work setting. Okay. So the ones I've got here that aren't there is your example should describe how you ensure your method of interaction is appropriate for interacting with basically different groups of people, researchers, technicians, interacting with students or trainees, interacting with external colleagues. Okay. So how I've put how do you work effectively in teams, and then housekeeping problems. I mean, there is no right or wrong answer. So you can answer these things in so many different ways. Demonstrate skills that you use to interact with colleagues. So tell me about different colleagues you interact with, and what different skills would you use to make that interpersonal and behavioral interactions effective in your estimation?
I think a lot of it is, again, it's adapting to sort of those known variables. So you get some people who you can be quite blunt with. You get the people who you need to be a little less blunt with them, especially if something hasn't quite worked out in the way you want it to, or if there's been an incident, or there's one particular, so she's actually a medical examiner's officer at Colchester, but she gets very, very skittish, shall we say, during winter. And you have to say to her very politely, we work in a mortuary and bereavement service. It's winter. We're going to get more people coming into our care, and that is normal. You effectively say, don't freak out. It's November. This is what happens. But with her, you can't be that blunt. So you have to go, this is expected, and it's how we get through it, and give her a little bit of a pep talk.
That's great, because it really is talking not so much about the language you'd use, it is about interpersonal and behavioural skills. So this is a very good example of that, Lucy. Yeah. Brilliant. C3, which is really, as it says here, is potential overlap in your answers on the C competencies. C3 should be where you focus on team working. So I've put, how do you work effectively in teams? I suppose there is a big overlaps. So large teams and one-to-one. So what do you think constitutes effective teamwork? How do you, in your experience, try and sort of do that, Lucy? And also, it's also about working with people in whatever capacity in terms of interbehavioral and communication skills on a one-to-one basis. So give me examples of what you think constitutes effective work in teams, the logistics of working in teams, challenges, responding to unexpected situations, and if you were working with someone on a one-to-one basis, what would you do differently?
So with the bigger teams, I think a lot of it is communication, because the more people you have, the more likely a misunderstanding is there to occur, or things get misconstrued. I think a lot of it as well, I'm thinking of the relationship that we have with the medical examiner's office. So they're the ones doing the getting the doctors down to write the medical certificates. It's understanding what their challenges might be that will have a knock-on effect to us later. So if we've had an influx of people in, if they can't get the junior doctors down, if they're on strike or whatever, that will lead to a capacity issue for me later on. But it's having those open lines of communication where you go, hey, you can tell me if you're not going to get through all of the weekend's patients by Tuesday afternoon, like it's absolutely fine, or I've just got to go on charge.
Yeah.
But I think communication is everything, because the more people you've got, the more room there is for different interpretations of the same message. So just making
Okay.
sure that, again, taking that stock check moment, this is what we need to achieve today, this is how we're going to achieve it. One-on-one, which is what it's been with Dave and I at Ipswich now for a few weeks, taking the fact that we're husband and wife out of the equation. If that was anybody else, say if that was Darren at Colchester,
Yeah.
it would be, it's recognizing that it's going to be a little more of a high pressure situation because the work of 7 people is being done by 2. But it's how you again check in with each other, communicate, as daft as it sounds, make time for tea and digestives, because that's what's going to see you through. And again, there's still the same sorts of conversations, but you tackle things in different ways. Like, right, this is the plan. These are the 3 things that we have to do today. These are the additional 2 things that if we have time would be great. And everything else we can worry about later in the week. But that's what we've been doing at the moment. So I've been making the plan, because although Dave was the senior APT at Ipswich, he's not anymore. And it's me that is the substantive member of staff. Like, right, this is what we're doing today. And then, just making sure that he's kept buoyant. He does like a pan au chocolat, so he's been bribed with those.
Oh, I
But
can
no,
be
I
very
think
easily.
communication's vital.
I can be very easily bribed with pan au chocolat. I absolutely love them. And my story in that regard, if you want to call it a story, is about 20 years ago. I'm showing my age as usual. I had the opportunity to go to a work meeting in Paris, and I have to laugh because the place I was working in Edinburgh said, look, a lot of the people that we want to talk to, a progress meeting about what you're doing and what the rest of us are doing. So, what you do vis-a-vis how it embeds into the wider sort of, collaborative sort of project objectives. They're going to be in a meeting in Paris, the people we want to speak to. So it would make sense for us just to basically nip over there as they're already there and go to Paris, and I had to laugh because they said, have you got, do you mind, do you mind going to a meeting in Paris? Which to me, to me was like saying, do you mind eating, do you mind eating the best chocolate in the world? No, I have no problem with that. And I mention that because I know what a terrible fate, eh? If it had been Hull, no disrespect to Hull, that might have been different. But Paris?
Oh yeah.
No, I don't have a problem going to Paris, particularly if you're paying. And I mention that because I thought when you're in Paris, you've got to try a bakery, haven't you? And so I wasn't going to buy bread because I was in a hotel. I got no butter and things. So, well, I've got to, you hear so much about French patisserie. So I thought, well, let me get a pan chocolat. Honestly, Lucy, it was a totally different experience to even the very best pan chocolat I've had here. It was amazing. The pastry was like nothing I'd tasted here. It was just in a different league. Have you been to Paris at all?
Once, but it was about 25 years ago, so I need to go back.
Did you try? Did you have the pleasure of trying one of their many patisseries that are all over France?
I don't think I did. I think I
Yeah,
was
you
very
should.
boring.
Yeah, you should, because everything's so fresh. I mean, I remember working about 15 years ago with a French technician in Nottingham. This was a few years later. The sort of place I was working in Edinburgh. She said she couldn't believe that we don't eat fresh bread here. You keep bread for days. Why? We always eat fresh bread in France, but it's like a religion there, isn't it? Fresh bread and cake. So everything is fresh and baked locally. It just tastes better. Anyway, back to this. Enough about French bakeries. So, professional practice. So, there's a lot of overlap between D and A, and really, if you talk about something, let's say in A1 and A2, as opposed to data evaluations, A3, you could just, or you can expect in terms of assessment, picking another method for, let's say for D1. But the difference is that for an RSci Tech, in a nutshell, in A1 and A2, it's about being able to explain a standard operating procedure, and perhaps knowing which method to select in A2 for a particular niche procedure. And as I say, if it goes wrong in A3, how do you identify that, and what do you do, even if it's like, referring it up the chain, because, you're not meant to have that sort of independent mandate in terms of knowledge and maybe your own responsibilities to change things, although you do, Lucy, which is why I think we do need to look at a higher register. But in D1, you are expected to talk a little bit about reviewing, not just reviewing and selecting, but maybe improving on a method a little bit. So I'm just reading here. So recognize problems and apply appropriate scientific methods to identify causes and achieve solutions. So we're looking for an example of where you have problem solved. So in other words, you are troubleshooting, you are improvising on a standard method. And it says here, the example in the sort of unexpurgated version of that is troubleshooting a method, reducing hazards and waste, improving processes after researching alternatives. So no doubt we've talked about this, but when you think about this in the context of D1, what springs to mind, Lucy, based on what I've just read? I'll keep that up.
So many things. So it's completely out of the left field here and not related to any other example I've thought of today.
No, that's good, because let me just say, when it comes to your own competency report, you want to use as many different scenarios as you can, reflecting maybe a wider remit as a CSci. But no, I mean, if you want to pull out different examples and use different examples for different competencies, and this is what you'll come across in your own assessment as well, please do. So carry on, Lucy.
So think about identifying a cause. So it's where we have, so in the post-mortem room, you have downdraft and air exchanges, just to make sure that any pathogens are quickly zipped out of there, just to minimize any sort of infection risk or spread. Where we have that serviced, audited, found it's not working, or found that the air exchanges are not changing as quickly as they should, it's how we look at either getting that fixed or how we determine if it's working or not. So taking a sample, liaising with the guys in the lab and looking at what's actually in the air to see if the air exchange is working. It's a little bit left field, which is where my brain has gone at this time on a Sunday afternoon. Or even if we look at, again, it's a little basic perhaps, thinking of the sort of the right tool for the job. The different blades that we use on the oscillating saw, depending on the task.
Yeah.
So different skull thicknesses, spinal cords, whether you're doing an anterior or a posterior spinal cord removal. There's so much I could talk about there, I think. A lot of it, I mean, the whole air exchange thing might be quite far down the list, but it really is, it's the right tool for the job. We've got an issue here, what do we need to be doing? I'm thinking of spinal cord removal too. My brain is like Manchester Piccadilly today. There's a lot of trains leaving the station at the same time. But
Don't worry,
this is good.
Lucy.
This is good.
No.
Yeah.
You're doing fine. You're doing fine from my point of view. So you get the idea with D1.
Yeah.
Okay, it's the one area as an RSci Tech where you or someone you might assess is got to sort of not just select an alternative method and explain the science. They've got to show that they've maybe done a little bit of troubleshooting. Okay, even if that's in association with others and they've gone away and they've had to read about it in order to trial something. Do you see what I'm saying?
Yeah.
So
Absolutely.
someone that assesses, it's not that they're meant to have independent knowledge, but maybe their supervisor will say to them, and I don't know how this works in your area, look, there is this way of doing something. Can you go away and read about it and then maybe trial it and see how it works? So you are troubleshooting, but you're doing it with guidance, which is always what's sort of appropriate for this level of register. Now, let me digress by saying that you are troubleshooting, aren't you, Lucy?
Yes.
Based on practice from your past. You're not having to go to somebody and say, what papers should I read? What do you think I should try? Which is why, because of your extra autonomy rooted in experience and practice, you should go for RSci, and I would say CSci, which is why we need another method. Okay, so D2 is about how you use resources effectively. So have a read of that, Lucy. And as you read that, resources could it be cost effective, how cost effective something is, the time taken. So how do you plan for a particular procedure, being mindful of things like how long it will take, IT considerations, um, anything that you can think of in that regard in your context? Okay, how do you use resources effectively? How do you plan and organize in that sense? What sort of things do you think about in terms of your excellent practice?
So D2 and D3 are some of the ones that I assess, and I think for my RSci Tech application myself, I can't remember the specifics, but essentially, again, it's the right tool for the job, isn't it? Based on experience. So where you've got
Yes.
somebody with a particular sort of skin texture, if you've got somebody at an accelerated rate of decomposition, you would use a different sort of suture, different sort of needle. Maybe you'd use glue as well as twine. Maybe that you'd use different sorts of wadding to make sure that the person was respectable and able to be viewed. So I'm thinking more sort of reconstruction there. There was a gentleman actually that I reconstructed. He'd been hit by a train, and his family were insistent on coming to see him. And because of the different types of sort of wounds and lacerations that he had, especially on his hands and his face, I
Yes.
used different gauges of suturing twine, different needles, different stitches, even to make sure that he was as good as he could look, well, given the circumstances. But given the circumstances, he looked pretty good anyway. Because I've seen people come off far worse. But as his family was so insistent, they wanted to see him, wanted to hold his hand. Again, that's all experience. It's knowing how the skin might come together, knowing the different stitches that you can use, knowing what the result will be before you get there because you've had experience of it before and know what works and what doesn't, which really helped me out there. But there's a lot around there, especially when it comes to the different sort of skin types people have. You can tell if someone spent a lot of time on a sunbed because of how their chest comes together versus how their stomach skin comes together. Your body will always dob you in. We will always find out about what you've been up to. So
Right. Well, I think we've probably got about another 10 to 15 minutes. Is that okay, Lucy? This has been a
yes, yeah,
lot longer than I thought. So
that's all right.
essentially, D3 is about, and you've really talked through this a lot, so we don't need to go over it again. And this is really for you to be clear in your mind. So it's basically about continuous technical process improvements. And the idea with RSci Tech is that you talk about how you've done that, maybe based on advice you've been given in terms of reading, evaluating, maybe a pilot method or a new method. But you're not meant to, as an RSci Tech, bring in fundamentally a new method to replace an old one, or to sort of improve on a process independently. Now you do that, don't you, Lucy?
Yes,
Which is
yeah.
why I think there's a case for you going, as we keep saying, for the higher register. Okay, so this is just really cross competency narratives where you could talk about, for example, something you do in A, and it's routine and it's established. In other words, there's a standard, sort of indelible standard operating procedure, but perhaps over time you improve it in terms of sustainability or reducing waste or reducing hazards. So there's that cross competency thread, that sort of crosstalk. Can you think of examples of things that you've done maybe 2 years ago that were standard that have been changed in that regard to make them more ecologically compliant or compliant with new legislation? So things inevitably have changed, they've evolved. Can you give me an example of that, maybe, Lucy?
I can. So again, as sort of mundane as it might sound, there was a lot of call for sort of safer sharps on the back of some new health and safety legislation that came in. Because we use blades called PM40s, which are basically massive scalpels. So the blade's that long rather than that long. Although I do like a scalpel for some of my finer work because sometimes again, it's the right tool for the job, isn't it?
Sure.
But with our PM40s, they have a very, very sharp end. And because of the risk of something that we call buttonholes, which is damage to a patient. So it's where incisions start about here. So my tattoo will be ruined. And then we work up and we free all the structures of the neck and the tongue and then bring everything down. We don't just take out from here below, we work up, but the incision is kept quite discreet. So if you're wearing a jumper, you wouldn't know that you'd had a post-mortem. There's a risk with the very, very long blades with the very, very pointy tip that you will go through and damage and create a hole where you really don't want to be creating any extra holes in a patient because then it can be seen, it's really obvious, quite distressing and completely avoidable. So they brought in something called the bull-nosed PM40 where you've got a blunt tip.
Yeah.
So that's not going to damage any of the soft tissue. So again, that reduces the risk to the patient of accidental damage, which is then a reportable incident to the HTA. It limits the distress to the trainee APT because you're usually a trainee when you're, more at risk of causing that kind of damage to a patient. So again, it's bringing in bull-nosed PM40. So I didn't work at Ipswich at this point. I was at Colchester. But I was on a health and safety course with somebody who worked at Ipswich. We had safer sharps, they didn't. And so I said, yeah, that's something that you guys should be doing because one, it then matches practice across the trust, but two, if there's a safer way of working, then you should be using it. Stop using blades that are going to cause a risk to the patient. So they've brought that in as on the back of that, which is great because I was very, very pleased. With the first time I walked in that PM room at Ipswich for the first time in years, they've got bull-nosed PM40s. I was delighted. Like, brilliant. That's a massive win. That's a massive win. And it's such a little thing. It's just changing the blades that you use. But
brilliant.
Yeah.
That's great. Okay, so we're coming to the end now of the actual granular competencies and subcompetencies thereof. E consists of complying with standards, professional body code of conduct, standards you comply with, your commitment to EDI initiatives, your ethical principles. And so E1, for instance, is comply with your professional body code of conduct, manage your work against all relevant legislative principles. Well, there's loads in your area, so you could enunciate those. It even talks about home office regulations, GLP, local codes of practice within your own, say, mortuary. And then E2 is really about maintaining and enhancing competence in your own area of practice through CPD. I'm guessing, Lucy, that it's not necessary for us to talk about that because you're very clear and there's a shitload of regulations that you can talk about. Yeah.
Absolutely. Yeah.
Okay. In terms of E2, which is CPD, regulations might change. So what sort of courses internally or externally do you go on or have gone on?
Oh, there's a heck of a lot. So the AAPT put on a lot of webinars. So diatoms in forensic analysis. There was a lovely one that I went on around causes of death throughout history. because
Yeah.
ultimately I'm an archaeology graduate, so I will always go back to that. There's the AAPT educational event every single year as well. The HTA put a lot on around consent taking and changes to standards that then we need to implement. So there's a lot around that. Are you getting up, Derek? Are you going to come this way? Derek has just hauled
Hello,
himself up
Derek.
out of his nap.
Brilliant.
You having a sniff? Is it dinner time? Your dad might sort you out. There we go. That was Derek getting down. So, but there's an absolute there's a lot, and there's a lot around where you may work in a mortuary, for example, that doesn't undertake specific examinations or specific testing. There's a lot of peer-led webinars and courses and conversations you can have with people as well. And that's the good thing about the annual conference, is that you meet people with the right mindset, and you can all draw on each other's knowledge and experience. It's great.
Perfect example. Yeah. Right. We're coming to the last two sections because we've actually spoken for 2 hours, 17 minutes, Lucy. So
Oh, crikey.
I know it's a long time, isn't it? So what I have here is really the mechanics, the interface of the application portal on the Science Council website. Now, just remind me, when you apply for, let's say, your RSci Tech, in terms of the full application or the abbreviated, is it done through the Science Council website, or is it specific to the AAPT?
The full one is through this portal, because I recognise this because I started it before they brought in the pilot for the shortened application. The shortened one is through the AAPT. So again, when I applied, I sent it to Christian Burt, our professional secretary. He uploads it and divvies it out to assessors, and obviously now I'm one of the assessors receiving these. So, and I think for the long route, it is still this portal. For the long version, you don't go through the AAPT. It is this way round.
Okay, so this is really self-evident. So if you've got a copy of this presentation, Lucy, which I mean, amongst other things, I've put it in the Teams thing, but do you want me to dissect this stage by stage, or can we just sort of go through it in a fairly cursory way? Because it's self-evident, like, you choose the register that you want to actually select. Well, RSci Tech, read the blurb, you pay your registrant an application fee, and you just work your way through CAP against these different criteria. So complete the career profile. The big bit is obviously your competency report, and we've dissected that. Any supporting documents, that, by the way, Lucy, can include things like vocational training certificates, for what it's worth. Okay. Brilliant. You can put those in. Provide details of your supporter, and then just complete the declaration, and then just hit the send button. So it's all sort of fairly obvious as you work through it, really. So before we go on to CPD and then finally finish, because I'm sure we both need a cup of tea, do you have any more questions at this stage about CAP? And if you do, you can always come back to me, of course, Lucy.
No, I'm happy with the portal. Yes, I must admit, I got quite far through it before they sent out some comms. There's a shortened route. Who wants to be part of the pilot? And I'm like, okay, I will.
Okay, so right. Well, this is really just giving you depictions of each of those sort of summary categories. So you're happy with it. So I'm just really flipping through that, therefore. And I thought we conclude, if you want to, unless you're happy with it, because we've been on for so long, with different types of CPD. Are you essentially pretty happy with CPD and the categories, Lucy? And obviously, once you get your professional register, year on year, you submit your CPD report to your license body. So the initial application goes through your license body or through the Science Council portal initially, but thereafter you submit a CPD report just to the license body. That doesn't involve the Science Council themselves. And these are just categories of CPD. Are you happy with all of this, Lucy?
Yes, yeah. So
Yes.
there's something we are going to start doing from next year in the AAPT as well, which is an award for CPD. So I know that the Science Council has the celebration of science every year, but we're going to start doing something similar at a conference, and I'm going to be an assessor for it. So
Brilliant.
yeah.
Okay.
Yeah.
So look, we're at the end. Hopefully, let me know in an email if you can see the recording. But as I think I said when I talked to you and Charlotte, the Padlet, and there's the password, is a really useful resource for anyone, really, experienced or otherwise. So have you taken a look at all at the Science Council Padlet, Lucy?
I haven't yet. No.
Yeah. If you've got any questions before you come back to me, please take a look at that because it's great. And there's your details. So make sure that you have got a copy of this presentation. I'm now going to stop sharing. I'm going to stop sharing and I'm going to stop recording. Right, stop. So